Thank you so much for joining us today. We have Dr. Michael Barnes, the Chief Clinical Officer from the Foundry Treatment Center here with us today, presenting on secondary trauma. Dr. Mike Barnes received his BA in psychology at Indiana University of Pennsylvania. He received his Master's of Education in Rehabilitation Counseling at the University of Pittsburgh and his PhD in Marriage and Family Therapy at Florida State University. Dr. Barnes is a licensed addiction counselor and a licensed professional counselor in Colorado. He is a diplomat in the American Academy of Experts in Traumatic Stress and a member of NADAC. Dr. Barnes accepted his first full-time counseling position in 1982 as an addiction counselor at First Step of Sarasota in Florida. Since that time, he has worked as an addiction counselor and an EAP counselor and a couple and family therapist in a number of clinical settings. He has also worked as an administrator and clinical supervisor in adolescent residential treatment programs, a crisis stabilization unit, and an acute care psychiatric hospital. Most recently, Dr. Barnes served as the clinical program manager for residential services at the Center for Dependency, Addiction, and Rehabilitation, and is a nationally recognized addiction treatment center at the University of Colorado Hospital in Aurora, Colorado. Dr. Barnes is the Chief Clinical Officer at the Foundry Treatment Center in Steamboat Springs, Colorado. He's the founder and director of the Michael Barnes Family Institute. He has worked with his clinical team at the Foundry to develop a family-centered, trauma-integrated addiction treatment process. His areas of responsibility include clinical oversight of all clinical programs, new program development, clinical supervision, and oversight of clinical record keeping. Dr. Barnes continues to present at national conferences, and we hope to see him at IPA in Indiana. And he focuses on the subjects of trauma addiction and the impact of trauma addiction on families. So I present to you, Dr. Barnes.
Thank you, Rosalind. So let me just start by saying I am just really thrilled to be here. I started my career at U.S. Steel in Pittsburgh as an EAP counselor intern, and then I've developed EAPs for Procter & Gamble, and I've worked I do work now for the United Sheet Metal Workers. So I like to stay involved in EAP as much as possible. But my passion these days, and so is on families, and particularly families who have been significantly traumatized. When I was at Florida State, our son, who was 5 years old at the time, got hit by a car and had near-death injuries and literally was supposed to die. He was not supposed to survive his injuries. And as a doctoral student, actually working with the top traumatologist in the country at the time, who had coined the term secondary trauma, I used to kid my son that he did not need to get hit by a car to give me a dissertation topic, that I could have figured out a topic to write a paper on without going through that. But in hindsight, he's fine. He's 37. But it really changed my career, and it really made my passion looking at what happens in family systems that are highly traumatized. And as I've worked in addiction since '82, I really started looking at how traumatized are families with addiction. And so I was asked to do a presentation for training for interventionists, and I decided to talk about why families don't do what you tell them to do, and they don't. And I think if we really begin to, or a lot of times they don't. And so I would guess that everyone in this Zoom call have had people ask them, what do you think we should do? And how do you think we should do it? And then when you look back, you realize that they really didn't do it. And so I've really been spending a lot of time over the years pondering those questions and talking to families about the question. And I get it at least twice a week. And What do you think the most common answer is when I ask them? I used to tell them, now I don't tell them. I say, if I tell you, will you do it? What do you think the most common answer to that question is? It's not no. That would make little sense. It's rarely yes. It's probably 98% of the time, well, it depends on what you tell me, which really opens the door to an incredible shift in that conversation. And most of you probably are aware of a guy by the name of Simon Sinek, and he wrote a really good book called It Starts With Why. And he really talks about the idea that people will ask you what to do and how to do it, but they don't do it because the most important question that they need to ponder is, why should I do anything? And so common in addiction work is that families believe that their role is to support their loved one's recovery. And the research doesn't tell us that that's the case at all. The research says that if an individual has a chronic disease, well, I can skip to the slide. Individuals who have a chronic disease tend to be much more successful in terms of their recovery when the entire family moves into recovery together. And so this idea that our program, and I don't know about you all, but during COVID, I cleaned out my garage, and I was going through my garage and I found this box that I hadn't opened in years, and I had no idea what was in it. And it was all of the papers that I had written when I was at Florida State, some of which were quite embarrassing, actually, but some of them were actually pretty good. And one of them, the one on the very top of the box, was, is it time for a family systems paradigm shift in addiction treatment? And when I read the paper, it was written in 1991. It was written 40 days before our son was hit by a car. And as I was in the garage and I sat down, I was thinking about it, and I thought, I wonder how different this paper would be if it had happened after the accident, where I really saw the relationship between trauma and addiction. And so I decided I would sit down and write a new treatment program, which I have. It's been being offered for about 3 years now. And so that's really what we're going to talk about. We're going to talk about how families are traumatized and how secondary trauma looks just like PTSD. And so when I was teaching at the University of Colorado, I had a student that asked me one day, it's in an auditorium and there were a bunch of students, and she said, what's the best way to work with an unmotivated client? And I think it's good to start this discussion. Everyone in this room, I'm sure, has worked with someone that you have sort of thought, they're not very motivated. And so I reframed it for the students, and I said, I don't know. I've never worked with an unmotivated client. All my clients are highly motivated for something. Many are motivated for change and getting better and making changes. Some are motivated to stay the same, with the idea that it's really not their problem. And when we work with traumatized families, the key to working with traumatized families is the recognition that they are highly motivated to stay as safe as possible. And that's why they don't follow what we do. And that until we have a relationship with them, until we know they're like, one of the interesting reasons that I stopped telling people what I thought they should do is because they always said, we've already tried that, or we've already done that. And it really became at that point, a discussion about who was right or wrong. And I never liked it. And so the goal now, in my mind, if you're working with families, is to help the family move away from the idea that we're a family with a loved one who struggles with addiction to we're a family in recovery from addiction and trauma. And that when they do that, they begin to actually demonstrate all of the bullets that you see on this slide, that they begin to realize that we've all been impacted, that we all need to work. I did a research study when I was at CEDAR, the Center for Dependency at the University of Colorado Health. And we were just, it was a bunch of questions to see when families enter family programming, what is their knowledge? Like, do they understand disease, and do they understand trauma and those things? And that one of the questions was that living with a family member who is struggling with addiction is traumatizing. Yes, no, or agree, strongly agree. 75% of the families, and there was an N of about 260 family members, said that 75% said that we strongly agree that living with someone who has an addiction is traumatizing. And then another 20% said that they agreed. Only 5% of the individuals in the survey did not see that it was traumatizing. And so think about how much training you have seen. We all get 1,000 emails a day on come to this training, come to that training, come to this institute, come to that institute. How many of them do you see that say, come and learn about secondary trauma? Come and learn about the impact of trauma in families. And I'm going to guess you don't see very many. And I think as a family therapist, my view of trauma has really changed over time. And I think we have a false belief system, or our conceptualization of trauma is too linear. That we believe that an event happens, a person experiences it, they have symptoms, and they either go to treatment or they get better or they don't. And I don't think that's accurate. I think an event happens, a person experiences it, but everyone who loves that person is also impacted by that event. If you go back to your DSM-5, or what's the newer one, desk reference or whatever, it talks about family members can be traumatized by witnessing an event or learning about the event. And when our son got hit, he had serious injuries. His mom was standing 10 feet from him. He was running to her when he got hit. And so he had significant trauma. She had significant trauma. But I was at school. I was at the clinic where I always was as a doctoral student. And my experience was much more in the emergency search situation and in the intensive care unit. And my research was on the secondary trauma of parents of children who experience an event that results in pediatric intensive care treatment. Kind of my story. And so when that family calls you to say, I have a family member who's been traumatized, it's really, and I'll show you some slides of some data that I've collected over the years to show you how complicated it is for those families. And so that linear process is broken when the trauma happens, and that everyone who loves that person is also traumatized. And you begin to see this recursive process of, if I have secondary trauma and the symptoms of secondary trauma are the same as post-traumatic stress disorder, what is the impact of my need to control the circumstances after my loved one gets traumatized? Or I need to deal with my own hypervigilance and my own fear and my own inability to recognize the difference between being safe and feeling safe. So again, our goal is, as a treatment center, is to help as many individuals attain recovery as possible. And that we've learned that if families can accept that they've all been impacted, they've all been traumatized, they've all experienced the implications of it, improve communication and problem solving, integrate illness management activities into family routines, and rather than, well, when is he going to get out of IOP, to begin to realize that we're always going to be in some level of recovery. We're always going to be in some level of working as a family on this chronic illness that isn't going to go away. And then I think the most important is each family member demonstrating or modeling their own efforts towards improved emotional and physical health. And that research was not done with addiction. It was done with a wide variety of chronic illnesses. And this is one of the reasons I like the research. And it's one of the reasons that I use it so much, is that, addiction has moved into such a medical model, the treatment of it, and that if we're going to be able to ever provide the services for families that we want to, it has to fit within a medical model. And this is a model of chronic disease management, and what in family therapy we call medical family therapy, working with families and how they're impacted by a loved one's illness. And it's funny, I was talking with a friend of mine who presents with me around the country, and I said, you know, it's funny, I have never heard you once say the word family in any of your presentations. And he said, why would I? He said, I just assume the family's going to be really grateful that the loved one is getting better. And I said, well, they're going to be grateful, but it's going to change everything. Like they've already made all of these changes. So I want to show you, um, you know, maybe you've already heard a loved one who you're working with say, if my loved one would get sober, we could go back to normal. And that's impossible. It's impossible to go back to, like, the normal ship sailed a long time ago. And so what is normal? I actually just did this lecture last night and had a fabulous discussion with the marriage and family therapy students on, like, what do we do with the word normal? Like, what does that actually even mean? And so I always use a mobile to show family development and the idea, and each person in the mobile has a limbic system, and each person in the mobile has a polyvagal system, so that again, we always so focus on the neuroscience associated with the survivor of a trauma's response, that we tend not to think about the fact that his mother also has a limbic system, and you know, a vagus nerve, and you know, ventral and vagal, dorsal vagus nerves, and so I think it gives us a much more realistic view when we can recognize that if this is the person who has the addiction, or this is the person who is traumatized, that, you know, over the course of time, we'll use addiction because it's the way I have the slide set up. But this normal that we're kind of, that the family thinks they're going to go back to is what they were like. And I'll show you a model in a minute. What they were like before the addiction of this loved one actually happened. But what happens if there's transgenerational trauma? What happens if the parents grew up in families where there was chronic addiction? Or what happens when the parents grew up and there were mental health issues, or there were chronic disease issues? And so for some families, the normal that they kind of brought with them to this process was a normal that would be considered very much developmental trauma or transgenerational trauma. For other families, Paul Early, who's a fellow in the in ASAN, the American Society of Addiction Medicine, says there are 3 reasons that people become addicted. One is genetics, or epigenetics, to be more precise. And the idea that if you think back to the old twin studies, you know, that two kids who are identical in their DNA, and one gets adopted into a family with addiction, and one gets adopted into a family without addiction, and they have the predisposition for addiction in their biological family, the kid who goes to the family with addiction has a much higher likelihood of developing addiction than the kid with identical biology if he goes to a family without it. And so we're now moving away from the genetic theory to the epigenetic theory, and the idea of the environment turns genes on or off. Second is self-medication. So I might have no history of trauma in my family or addiction in my family, but I get hit by a car and begin to use drugs or alcohol as a way of medicating. And then the third one is that if you grow up in an environment where using excessively is normal, then it becomes normal and you develop it that way. And so this idea that over the course of time, as a loved one is kind of developing the addiction, and you've all probably seen Jelinek's curve. This is an old thing that we used years ago, but I like the progression of it, and families are able to really respond to it, and to begin to get them to recognize, when did they recognize these symptoms actually happening? And I said, well, you know, I don't remember some of those, but I remember this happening. And so getting the family to start to talk about, well, how did you try to address that? When you recognized that those symptoms were there, what did you do? And as you help them work through this progression, you can help them begin to realize that they've already created a new normal. And that new normal, it's why, to be quite honest, it's why I called my book When a Solution Becomes the Problem. And the idea that they have created a solution for dealing with an actively using person or family member. And when that person moves into recovery, up into this side, if that family continues to treat them the same way they treated them when they were using, how would you feel if you were a member of a family that has done a lot of work to get sober and your family still treats you like the identified patient? And so I ask families a lot, when your loved one walks in the front door of the house, how long does it take for you to determine whether they're intoxicated? And the average answer is 2 seconds. And they defend that by saying, well, we don't know what's going to happen when if he comes home and he's sober, we're going to have a very different interaction than when he's using. And then I will ask them, so let's just say your loved one has been sober for 1.5 years and you haven't seen them for a while, and the front door swings open and you look down the hall and there's your loved one. And how long, and I said, be honest, think about it. How long do you think it's going to take you before you think, I should probably check out to see if they're intoxicated? Now, you'd think after 1.5 years, that would be different. Across the board, 2 seconds. And then idea of, I just need to know. And so when that solution of learning how to live with an actively using person, it keeps the identified patient in the identified patient role within the family. And so as long as they're in the identified patient role, then the statistics and the research would tell us that as long as they stay in that role, that their chances of relapse are considerably higher. And that's why we're moving into this family recovery process. So does that, hopefully that makes sense, that idea of the goal is creating a newer normal to kind of move beyond a normal that takes the original normal into consideration and the roles that played in how the family evolved. And so if you look at this picture, it's just a mobile. And I just want to give you a context of what it's like in a house with someone who's actively, in a substance use disorder process, but also, the trauma piece. And so you can see it's got to be pretty hectic in that process with all the trauma symptoms and nightmares and anger and conflict. But the family members have those same issues. So for time, I'm going to jump over some things and go into the model. And so this is a model that was done by John Rowland. John is a psychiatrist. He's a professor in the medical school at Northwestern, and he is an expert in medical family therapy and dealing with families that are dealing with chronic illness. And he said that the key to understanding chronic illness from a family perspective is to understand 5 key phases or 5 key factors that influence how that family is going to manage the chronic illness. The first one is 3 generations of history. If those problems were present in prior generations, then the parents or partners that come together to create this family are going to come from a perspective of how did my family of origin deal with similar issues. And the chronic illness could be schizophrenia. The chronic illness could be multiple sclerosis. The chronic illness might be diabetes, might be addiction. And so understanding the 3-generation assessment, like doing a genogram of addiction, mental health issues, traumatic stress. I grew up in Pennsylvania. I grew up in central Pennsylvania, where the towns around us either had a steel mill, a coal mine, or a railroad. And mine was the railroad. And so everyone I went to high school with worked in the railroad. I was one of the ones that got away doing some other things. And so how many, if you know anything about coal mines or steel mills, and I did my internship at US Steel, how many people get injured or killed in a steel mill every year? There was a picture that I found in a file folder. And it was a picture of the mill that I was in, the Homestead Works, and there were 8 hearses lined up in front of the mill. And I said to the doctor that I was working with, that must have been a bad day at the mill. And he said, now looking at that picture, it was probably during Vietnam, and we were running 3 shifts every day, and probably 8 people died in the mill every day. So they were just lined up waiting to take people out. And so in a small steel town, Munhall, Pennsylvania, how many, if that's the case, how many families were dealing with grief and loss and trauma and addiction in those families? And as an EAP counselor, this was early, this was back in the early 80s. We were focused more on the employee than we were on the families at that point. And it's really nice to see EAP moving into a more broad perspective. So 3-generation assessment. And so the 3 generations of dealing with illness creates a belief system within that family about illness and health and help seeking and acceptance of information about what's going on. So we know that families with addiction will often close off their external boundaries and get very diffuse internal subsystem boundaries. And so it makes information really hard to get in and out of that system so that people can get help. And so it's my belief that it is these belief schemas that families bring to us that either support or inhibit help seeking, and either support or inhibit doing what they're told or doing what is recommended. I hate I don't like the way I just said that, do what they're told, but I mean the recommendations that we make. And so our health system beliefs and our beliefs about illness and about our faith in the external world influence our organization. And the organization is what we call the 5 R's. And those are the rules and roles and routines, rituals, relationships. So it's like the policy and procedure manual of the family, job descriptions for everybody in the family, your daily routines and those kinds of things. And they all begin to change as the chronic illness gets worse. And so how families will show up to treatment or how families will show up when they call you will be influenced by their beliefs about helpers, about therapy, about treatment, about illness. And so as those organizational issues and the rules begin to change and more secrets and more talking around the addicted family member, parentified kids and those things happen, that families don't move through the appropriate life cycle stages as they're supposed to. And so if you think about the stages of life cycle stages, it's this very fluid process that there are certain ages the kids need open boundaries so they can go make friends and go to school. And then we want to close those boundaries because we want to begin to now teach them how to be social in a way that's responsible. And then high school, they open again. And so if you have a kid that's in high school, a kid that's in middle school, and a kid that's in elementary school, those boundaries are going to be different for all of those kids. And so what happens in addiction and what happens in any chronic illness is the boundaries become less fluid so that the other kids in the family tend not to get to do the things that they're supposed to do. And that's why I question, is addiction treatment rehabilitation or is it habilitation? And I see all the time where we'll get these young men in who are 26, 25, they've been using since they were 12, and they never went through all of the developmental stages that they were supposed to go through. And when they get sober, they begin to realize, I don't know how to do anything. I had a 38-year-old guy who was leaving treatment, and he'd been through multiple treatments, and he said, I got to tell you, I'm terrified. He said, everyone's going to expect me to go out there and operate like a 38-year-old man. And I've never even paid my own taxes. My parents have paid my taxes. And they've paid my rent. And I've never had a lasting partner. And so the understanding that as long as that's the case, who stays in the parental role? The parents do. And so do they get to then enjoy the fruits of their kids launching? I was sitting in a treatment team meeting and I was listening to everyone talking about this family and what they were doing. And I said, my memory of that client is he's like almost 60 years old. And they said, oh yeah, he is. The parents are 85 years old. And so the idea that the parents have never been able to shift into their developmental life cycle roles of the kids being gone and redeveloping their relationship and those things. So that how families move through life cycle stages influence really the long-term family relationships, how much resentment there is, how much individual development is allowed. And then we see the last one. And so if we're going to look at my model of therapy, I don't have the slide in here. I took the slide out. So take this picture and put trauma in the middle of it. And now we have addiction and we have trauma and we have hypervigilance and we have control, and see how that begins to impact families' appropriate movement through these various developmental stages. And so if we look at some of the stories that I told you a little bit about the cedar, but this is a quote. We'll just do this one quote for time. It was a mom of a 20-year-old female client who was addicted to heroin. And I was doing a research project and I was interviewing families, and her interview has stuck with me for years. And it says, it's really been overwhelming. I can sit here calmly and talk now, but that's not the same as what I don't know where my daughter is and what's happening. I'm getting phone calls from somebody on the street saying that she's been beaten or she's been raped. Really bad things are happening to her. It's not such a calm feeling when you get those phone calls, or you get phone calls in the middle of the night. I think there's some sort of post-traumatic stress disorder for families going through this. And so it's really important to begin to look at the research of what do we know about the experience of families when someone is traumatized. And there are several things, and in my research, I call them axioms and like testable hypotheses. But the first one is that living with a family member with addiction and trauma actually is traumatizing. That family members will show the exact same symptoms of post-traumatic stress disorder that the client does. And they have anxiety and fear and anger and control. Families go through a very similar what Annie Camacho, who actually does most of our program, they have a very similar parallel process to what the client's going through, and understanding that it is a chronic disease and that they are powerless to controlling it. And so anxiety, intrusive thoughts, families will talk about, I'm supposed to be working, but I'm sitting at my computer wondering if my son went to the doctor like he was supposed to, or got to that AA meeting that he was supposed to go to. They have nightmares. They all talk about sleep disturbances and having a hard time falling asleep and having a hard time staying asleep. Control, hypervigilance, detached and estrangement from others. So often families who kind of resist going to social support services will talk about how lonely they are, how they used to have friends that they would talk to, but their friends, all they want to talk about is how's your husband doing, or how's your wife doing? And it's just too difficult. So avoidance of people and places, avoidance of activities. And so in the process of the research that I did with this mom, I asked the families, if you got a telephone call from a friend or from a family member who has a loved one who has been diagnosed with the same diagnoses as your loved one, and they want to know what life is going to look like for them going forward, what would you tell them? And so when I had 40 plus hours of transcripts, when I coded everything, it became really clear that the families all talked about a very similar process. And so if you look at this slide, this isn't from the research, this is from the families. And there were very clear common emotional responses. And they talked about them like coming in waves and coming in, depending on what was going on with their loved one's addiction or recovery, anger and fear and horror and depression, frustration. It's interesting, in another research project that I did, I asked families, what are the most common traumas of living with someone with active addiction. And the first one they told me wasn't a trauma. It was a grief issue. And they said the shattering of dreams and the idea that he's never or she's never going to be, as accomplished as we had hoped. Or if it's a partner, I came into this marriage with dreams of grandchildren and all of these wonderful times together as a family, and they've all been sort of shattered. And so while that in and of itself is a grief response, the reality is that how they kind of experience it actually is pretty traumatic. Like I got to get this under control before I lose my son. I got to get this under control before I lose my relationship. Very similar cognitive responses: helplessness, fear of the future, obsession, intrusive thoughts, uncertainty. Common physical symptoms: sleeplessness, worry, exhaustion, nightmares. Common behavioral responses: hypervigilance, control, caretaking, imposing structure, avoiding triggers, and then common defense mechanisms: denial, rationalization. So that when I finished, I started looking at primary themes, and I never used the word trauma in this research. I wanted to see if they would use the word trauma, but it became really obvious that they were traumatized. Like, that's pretty trauma-related stuff. The other thing that came out of it was there were so many negative comments about the treatment world and the medical world, and they were very distrustful that treatment was effective or helpful. They were very distrustful of, like, physicians, and this is long before Suboxone, but the idea of giving medication, we're trying to get them off of medication, things like that. So the second thing that we learned in our research is that the longer a family stays in fight or flight, the longer this progression goes on, the more they shift their coping strategies and their worldview away from our values and our goals driving our decisions to personal vulnerability and safety driving our primary coping. And so Ronnie Janoff Bowman, back in the 80s, wrote an interesting book on how cognitive schemas of safety get shattered with trauma, and that the world moves from a safe and relatively benevolent place to a really dangerous place, and that the world ceases to be meaningful and becomes random. So that even being the most responsible person in the world can't prevent another trauma from happening. And that good things don't happen to good people. Bad things happen to good people just as much. And that once those become the primary schemas, then control and hypervigilance make perfect sense. We would all have control and hypervigilance if that's what we believed. And so in addiction treatment, we talk so much about things like enabling, and so much about things like, enmeshment and boundaries. Think about the process of enabling. And so there's a new concept, a guy by the name of Rob Weiss, he's a sex therapist and a family guy from California. And his book is called Pro-Dependency. And the idea that codependency is really loving behavior with bad boundaries. Like, you get too involved in your loved one's life. Codependency is loving behavior with healthy boundaries. And so to tell a family member to stop enabling is kind of like Nancy Reagan telling an addict to just say no. If you're not going to teach them how to do it, and you're not going to teach them tools, then don't tell them to do it. And so what I started looking at was having family members tell me their enabling stories. So what was it like? Well, the door opens and he comes in, and I know it's that day of the month where he's going to ask for money, and my therapist has been telling me not to give it to him. And I start trying to tell him, and he gets angry, and my heart starts racing, and there begins to have all that sympathetic nervous system response, and I just give him the money to make the fear go away. Well, that's enabling, but it's also a pretty clear trauma response. And so we really need to teach families how to build support systems around those decisions on how to kind of resolve those. The other thing that this is a map. You've all heard of Peter Levine. He's the kind of big trauma guru. And this is Peter. This is a map that Peter and another guy developed that shows the more threat we have, which is the x-axis, we go from being relaxed to stressed to highly stressed to traumatized to severely traumatized, meaning, and all this, you're going to get these slides so you can spend a little time on it. We know that the prefrontal cortex starts going offline right where my cursor is. And so one of the things we have to teach them is if their worldview now is that the world is dangerous and that their family member is potentially threatening, that every time they make a change, it's going to result in, conflict. And so we spend a lot of time trying to teach our families how to kind of, the clients call these marbles, and they're not if you have marbles in your nervous system, you probably need to go to the doctor. These are what Levine called tractor states. And it's Levine's belief that when we have unresolved trauma, that energy gets trapped within the nervous system. And that as we have additional traumas, it makes our response to those significantly higher. And so, but the clients talk about the marbles, and I love hearing families talk about, well, my marbles are moving up, and we need to have a few minutes to talk, like to cool down before we keep this conversation going. And this really helps them begin to kind of process information differently and communicate differently. We have this poster in every group room in our facility. And so that we can say to clients that we're watching get elevated, because we want them to learn what they're feeling is really a nervous system response to a threat. And to say, well, where are your marbles right now? And I'd say, well, I was pretty relaxed when I came into group today, and I'm pretty amped up right now. And so we can begin to get them, if we look at this poster, this is the other poster that's in every group room. The idea of the moving of energy from being stressed to very stressed will be accompanied by a certain set of cognitions and thoughts, certain feelings and emotions, certain somatic responses, and certain impulses. And it's really helpful to have that client begin to look at, well, it started when we started talking about this, and I started feeling bad. And I'm like, my hands were getting cold. I'm starting to dissociate. And my impulse was, I need to get us to change the topic in this group. And so when families can talk about their own arguments using these tools, it's really helpful. Time-wise, we don't have a lot of time, so I want to just finish the other parts of this research. The other thing about the research is that perception is way more important than reality. Remember that whole family schema, health and illness schema. If you think about how people problem solve, this is an old model called the ABCX model, is they have a stressor, they have resources to use to fix it, and they have perceptions or understandings of what that stressor means. And those perceptions come from their family of origin, trauma history. And Shaw and Halliday back in 1992 said, the crisis isn't the problem. What the problem is the family's constraining beliefs, perceptions, that restrict alternative views about the crisis that becomes the problem. Is that we have a stressor and we only use the resources that we believe meet our understanding of the problem. I'm sure everyone in this room has come up with a plan to help someone, and the family or the individual didn't do it. And they probably didn't do it because how the services that you're offering them somehow didn't meet their understanding of it. And with traumatized families, as we're trying to help them move into a healing process, that we have to start with their understanding of illness and their understanding of trauma, and we kind of begin in that place rather than, well, we need to give you a bunch of services to get you where you're going. And I think in EAP, we can do a lot. And a lot of EAPs have like that 5 or 6 session, and we try to fit a bunch of things in there. But I think if we can really focus on what is their understanding of the problem and how do we map that with them. And so the last thing that came out of my research was that the concept of systemic trauma, and that if you have a whole room full of traumatized people, and that they all have their own need for control and their own need for hypervigilance and their own need for safety, that you're probably going to see pretty significant shifts in family organization. The rules of communication are going to change. The roles that people play are going to change. Daily routines are going to change. Increases of conflict and resentments and anger, emotional distancing, intimacy issues, triangulation, those kinds of things. And so ultimately, these are issues that are part of the new normal that they created, trying to learn to live with the addiction. And this is the person who's really walking into our office in most cases, not the person in the earlier stage. And so, again, it's really important when working with these families to understand that they're assessing you way more than you're assessing them. I mean, our job is to assess, but their job is to stay alive and to stay safe. And so they're watching every move you make. They're watching your facial expressions. Who was it? I can never remember the guy's name, Katzarian or something like that, who said that only 7% of communication is the spoken word. 93% of all communication is our facial expressions and our nonverbal communications, our tone of voice, our ability to attend. And so it's really important to be able to do that. And I'm going to say one more thing, and then we're going to take questions. But I want you to think about bottom up and top down processing. And that if we use this map, and we know that the prefrontal cortex starts going offline right about here in the middle of between stressed and strongly stressed, that means talk therapy's value ends there. That if I'm now in a state of sympathetic nervous system activation, I'm probably not going to be able to attend to the level of cognitive discussion that we need to have. And so from a somatic experiencing standpoint, we talk about the idea of moving from top down, cortex-driven conversation, to bottom up, limbic system driven. And so they talk about pendulating, and pendulating is working on what you were working on, doing the talk therapy, doing the planning conversational work. But as the client gets more activated, to shift out of that, go into grounding, go into resourcing skills, but bring that nervous system activation, or as the clients would say, bring the marble down to a place at which they can return to talk therapy. And then you can talk about what was it that, then you can go to this poster and say, what was it that started the shift? What were you thinking? What did I say? Or what did we talk about that caused your nervous system to activate? And that you're kind of constantly moving between these two. And you can get so much more work done when you do that than continuing to work on talk therapy when the clients think about it. If you're in fight or flight, do you want to talk or do you want to fight and flight? And it's the same thing with emotions. Like, no one in fight or flight has gratitude. I mean, why would you? Your body is taking over. And so that's the thing that I've learned, that it's changed my family therapy completely. Like the intent is still the same, but the actual process that I'm doing in a room with family members is really different. And I think it's really important to understand that there's individual safety, but there's always systemic safety, and that they will always demonstrate the changes in organization to you. I say to my staff a lot, why are we upset with a traumatized client acting like a traumatized client? Like they're doing what they're supposed to do. Like, use it, accept it, and help them with it. So I think that's I mean, there are other slides in there that when you get them, if you have any questions, please feel free. My phone number, I think, is on the, yeah, there's my phone number. Here's ways to get a hold of me. Actually, the best place to buy my book is at Barnes Ed and Consulting. We changed the website a little bit, but what questions do you have? We have about 5 minutes, 6 minutes. Hi, Libby. How are you? Any questions?
Does anyone?
Really, thank you for this. It's very clear. For me as an EAP, sometimes I don't know kind of how to succinct some things in when I do an assessment, and where I need to lead people. I just dealt with somebody this morning who, like you said, they say one thing and there's a lot of excuses for the other piece. And so as a clinician, it's important, I think, not to take it personally, because I think it also adds to our burnout or compassion fatigue when we take it personal that people don't follow through.
Yeah, it's really true. And the other, like, something I didn't talk about that I think is really important is the concept of what narrative therapy calls inherent paradox, and Libby was referring to, like, they say one thing and doing another thing, and there's really those are wonderful opportunities to begin to say, I'm hearing you say a couple different things. Let's, like, using motivational interviewing. We tend not to think about motivational interviewing with families. And what do we do when we have a client that's pre-contemplative? We use motivational interviewing. Why not use motivational interviewing when we have a family that's pre-contemplative and begin the same interventions? So any other thoughts or questions? Hopefully it all made sense. And check out the slides and let me know if you have any questions. Thank you. I appreciate it. And Rosalind, thanks for the opportunity.
Thank you, Dr. Barnes, so much for joining us today. This was a fabulous presentation, and we look forward to hearing more from you in Indianapolis.
Yeah,
And again, if you would like to request slides and/or PDH for this afternoon's session, please feel free to drop your name and email address in the chat box, or you can send me an email at membership@eapassn.org. Thank you so much.
Thanks, everybody.